It is my pleasure. Last but not least, Dr. Bart van der Worp, former president of the European Stroke Organization. Bart is a neurologist with a special interest in cerebrovascular diseases. He is based in the University Medical Center in Utrecht in Netherlands, and he's the head of the cerebrovascular diseases program over there. He has been the chief investigator for many randomized clinical trials, and many of them have changed clinical practice. Bart, thank you so much for agreeing to present this challenging topic of the management of TIA and acute ischemic stroke in people with hemophilia. Thank you so much, and looking forward to your presentation.
Thank you, Aristides. It's a pleasure to present the guidelines on the management of TIA and ischemic stroke in patients with hemophilia. And I acknowledge this is a very rare condition. For example, in the past 10 years or so, I don't recall having seen any patients with a TIA or ischemic stroke who has hemophilia. I've only seen bleeds, and this is despite the fact that our hospital is a reference center for patients with hemophilia. Nevertheless, observational studies suggest that this complication does occur, so it's important that there's a guideline. These are my disclosures, not relevant to this guideline. And the recommendations for patients with ischemic stroke or TIA are embedded in this guideline on antithrombotic treatment in patients with hemophilia. This was initiated by the European Hematology Association and supported by ESO. And most of you will know that hemophilia is an inherited bleeding disorder caused by coagulation factor deficiency. So factor VIII deficiency is hemophilia A. Factor IX deficiency is hemophilia B. Both are X-linked recessive conditions. And factor 11 deficiency is hemophilia C, which is autosomal recessive. And the present guideline only deals with the first two. It's also important to know that in the literature, hemophilia is categorized by severity. So severe hemophilia is defined as having a factor activity of less than 1% of the general population. Moderately severe hemophilia has a factor activity of 1 to 5% of the general population, and mild hemophilia has a factor activity of 6 to 39% of the general population. Hemophilia itself is also pretty rare. It's hemophilia A is found in 1 in every 4,000 to 5,000 live male births, and it's important to know that about half to 2/3 of them are severe. Hemophilia B is even rarer. It's found in 1 in every 15,000 to 30,000 live male births, and 1/3 to half is severe. And especially in severe patients, they can be treated with prophylactic therapy consisting of clotting factor administration in the absence of bleeding. So for this guideline, the grade system was not used, and the European Hematology Association explains this by the fact that the evidence is largely from observational studies. And I think in this audience, it's needless to say that you can base guidelines, you can use the grade methodology in guidelines based on observational studies, but this is how it's appeared in the guideline. They did use a 3-level grading system consisting of recommendations, considerations, and suggestions. And in the end, actually, most of the recommendations, considerations, and suggestions are based on expert opinion and extrapolation from the general guidelines, such as the ESO stroke guidelines. So the first question asked is whether patients with hemophilia are naturally anticoagulated. And experts in this guideline working group said that the patients with a clotting factor level of less than 10 international units per deciliter should be considered naturally anticoagulated, comparable to an INR of 2 or higher in the general population. Also, patients with slightly higher clotting factor levels of up to 20 international units per deciliter should be considered naturally anticoagulated, but it was comparable with lower INRs in the general population of 1.5 to 1.9. And for patients with higher clotting factor levels, higher than 20 international units per deciliter, there's a large inter-individual variation. So the next question is what the threshold is to safely start aspirin or oral anticoagulation. And for patients with clotting factor levels of less than 1 international unit per deciliter, so these are the patients with severe hemophilia, and these are also, this is the majority of these patients, antithrombotic therapy is not recommended. So not for myocardial infarction, but also not for TIA or ischemic stroke. For patients with slightly higher clotting factor levels of up to 5 international units per deciliter, that's the minimum level of single antiplatelet therapy. And 20 international units per deciliter is the minimum level for dual antiplatelet therapy or for starting oral anticoagulation. So the recommendations for patients with acute ischemic stroke can easily be summarized with this very simple figure, which is not surprising. So for patients who present within 24 hours after stroke onset, you should consider mechanical thrombectomy based on the regular guidelines. So for example, the ESO guidelines, but the difference is that patients should receive clotting factor concentrates, preferably before the procedure, to reach clotting factor levels of 80 to 100 international units per deciliter during the intervention, and higher than 50 international units per deciliter for the next 24 to 48 hours. And for the long term, they should be treated with aspirin or a DOAC. And again, this is actually all expert opinion and has nothing to do with randomized trials. The main difference with the general population is that thrombolysis is not recommended, and that's because of the higher bleeding risk of these patients. For secondary prevention in patients with non-cardioembolic ischemic stroke or TIA, there the recommendations depend on the severity of hemophilia. For example, if we move to the right to patients with baseline factor levels of less than 1 international unit per deciliter, they should receive no antiplatelet therapy and no anticoagulation. If they do receive clotting factor concentrate prophylaxis, you may consider single antiplatelet therapy. And the same applies to patients with slightly higher factor 8 or 9 levels of 1 to 20 international units per deciliter. These patients can be treated with single antiplatelet therapy. And that also applies to patients with higher baseline factor 8 or 9 levels, higher than 20 international units per deciliter. They should generally be treated with single antiplatelet therapy, and that's mainly aspirin. Only if you consider that the risk of recurrence is very high, for example, with large vessel stenosis, you may consider dual antiplatelet therapy followed by single antiplatelet therapy, just like in the regular guidelines. Important to know is that you should always prescribe a proton pump inhibitor in patients treated with antiplatelet therapy, and that's because of the high risk of gastrointestinal bleeds in these patients. An important question, especially for the hematologist, is that starting or adapting clotting factor prophylaxis merely to be able to start dual antiplatelet therapy is not recommended. And for patients with cardioembolic TIA or ischemic stroke, as I already said, the minimum trough factor 8 or 9 level of 20 international units per deciliter should be considered for oral anticoagulation. And a DOAC is recommended over a vitamin K antagonist in patients with atrial fibrillation. And the dosing and INR levels should be the same as in the general population. So in summary, TIA and ischemic stroke are rare in patients with hemophilia, and secondary prevention with antithrombotic therapy may be given in specific cases, especially in patients with non-severe hemophilia. And my personal recommendation is that you should discuss the acute treatment and prevention with your local hematologist. Thank you.
Thank you very much, Bart, for giving us this excellent overview over this very difficult topic. That's much appreciated.